So good morning, good afternoon, colleagues, and welcome to this second in a series of 4 webinars brought to you by the Health Effects Institute. So in the interest of time, I think we can begin. And, before we begin, a couple of housekeeping announcements. If you encounter any logistical difficulties, please reach out to us through the chat box. We have chat open, so you can drop your name and affiliation and interact with colleagues in the chat. We would encourage you to send your questions via the Q&A. We will have 25-minute open discussion session where we can delve into the issues at hand, but we do encourage you to send in your questions via the Q&A function. You can also upvote questions that you feel deserve the kind of attention based on our discussion today. The webinars and slides will be shared after this session through the event website that is shared at the bottom of the screen there. We are on social media, so those are socials at the bottom of the screen. Please feel free to connect with us. So before we begin, just a couple of words about the Health Effects Institute. We are an independent research institute providing trusted science. You'll see some of our products here, including a systematic review of transport-related air pollution and the Global Burden of Disease MAPS project. We do scientific review on the health effects of air pollution, and our global health program, which brings you this webinar series, does work across the globe. We have a flagship sort of State of Global Air report that I'm sure you have interacted with. We do work in South Asia, East Africa now, and partly in India. One of the resources you'll see in the middle of the screen here that's very relevant to the East African context is an interactive literature database. It's essentially a mapping of health and air pollution studies in 8 countries. Our definition of East Africa spans the 7 East Africa Community member states plus Ethiopia. So this is the beginning of us sort of trying to see what is out there and available, and it's open to the networks and public, and we do encourage you to send in your studies as we are still collecting. We have about 160 studies, and you can see the darker the color of your country, the more studies there are. So Kenya and Uganda, maybe a few gaps in Burundi, which is still white. So we do encourage folks to send in their studies for inclusion in the literature database. So on to the subject of this today's webinar. There is, a famous saying in the African context that, African politicians can only believe scientific evidence when it's presented to them by African scientists, and that could be in the context of, international collaborations. So today we are going to see how that capacity can be strengthened, so that, we bring that evidence to the fore. In the first of the series, we discussed the issues to do with data and data gaps, both on the air pollution side and the health side. So today we're really taking that conversation forward to see who is it that when this data is available, we need that capacity to sort of interpret and analyze that data. So our agenda today is a shorter one, 1.5 hours. We will get to hear a few opening remarks from our 2 co-chairs, and we have 2 speakers lined up for you who will give you the perspectives on some of the research programs they've been sort of running on the continent. Then we'll have hopefully a 30 to 25-minute discussion and questions, and we hope to take maybe 1 or 2 questions from the floor as well. So stay tuned for that, and we'll close with some closing remarks from our 2 co-chairs. So to take us through this agenda, we have our 2 co-chairs on the immediate left, Dr. Lina Tuyambe and Dr. Catherine Tone, and our speakers, Dr. James Mwitari from the Kenya Medical Research Institute, popularly known as KEMRI here in Kenya, and Professor Bertrand Bachu from the University of Douala. He's also, the vice chair of the Pan African Thoracic Society. So before I hand over to Lynn and Catherine, I would like to introduce them both. So Dr. Lina Tuyambe holds a PhD in public health from the University of Karolinska in Sweden. He is the PI of the Eastern Africa GeoHealth Hub here in East Africa, but the Uganda chapter. The goal of that study is the goal of the project is to study the health effects of air pollution and climate change on health in Uganda. Dr. Tuyambe is a member of the steering committee of the African Field Epidemiology Network, or AFNET. He teaches both undergraduate and postgraduate students at the Makerere University, and has, a big number of peer-reviewed studies, over 100 peer-reviewed studies in different journals. Dr. Catherine Thorne is an environmental epidemiologist focusing on the health effects of air pollution from both outdoor and household sources in low and middle income countries as well as high income countries. She is a co-director of the Lancet Countdown for Health and Climate Change in Europe and leads working groups focused on mitigation action and health co-benefits. She coordinates a Catalyze project, which is a 5-year horizon Europe project focused on climate change and health. She has a PhD from the Harvard School of Public Health and a master's in public health from Columbia University. So welcome to our co-chairs. And at this stage, I will hand over to Lynn to take us through the program. Over to you, Lynn.
Okay, thank you very much. May I share something? I don't have the rights to. Okay. So thanks everyone, and thank you for prioritizing this this webinar today. This is an important issue because, as you will hear from our presenters, the issue of air pollution in Africa, in the world, but also in Africa, is catching up with us. And I will just give some short remarks, really, emphasizing the issue of capacity needs for converting research into practice. And I will try to illustrate a little bit to the institution I work for, the Makerere University and the Eastern Africa GeoHealth Hub. So some of you may have been here in Makerere already. So the issue is that really there is a big gap in converting research evidence into practice, especially in low and income countries. And this is mainly, in my opinion, because of the different issues and programs and problems that we sometimes face, especially in the low-income countries in Eastern Africa. So there's really limited funding, not only for projects, but also for programs and also innovations, limited funding for available for training institutions and higher education, for manufacturing, and also for different instruments. And this is a big challenge because once there is, excuse me, there's limited funding, then you don't attract, individual scientists to take up this track. So thus there's limited evidence also. Because of this limited research, then there's limited evidence for decision making, and therefore uptake of recommendations for action becomes a challenge. Here at the School of Public Health, we have tried our best, and Makerere, we some 10, 15 years back started a training specific program, another graduate program in environmental health sciences. And now, beginning 2 years back, we started a master's degree in environmental and occupational health. And we also have several others and other initiatives, especially the postgraduate small grants, stimulate action, stimulate interest among the young people to attract them into our business of environmental health and air pollution. The government agencies and departments like Ministry of Water and Environment, Ministries of Health, the National Environmental Management Authority, some of the big allies that are important within the country, because eventually when they take up the studies that we do, then we can see research to policy and then programming, which would have an effect. just to give an illustration, we've been doing a study on air pollution, and we started with we actually were the second institution to import in the BAM, and now we have got more equipment, but we still have limited capacity, limited capability, especially the trainees and funding. And once we generate a lot of evidence, then we get the opportunity to have more evidence into the window for policy and then practice. And some of the studies we have been focusing on lung functioning, blood pressure, cognitive development, etc. And just to illustrate the countries, the partnerships is also another important thing. I had once a policymaker indicating that once a study has been done with different partnerships across the world, most likely that evidence is stronger than a single institution. Some of our partners from North America and of course Africa, as I've told you, but also training scientists, young scientists is very important, especially for institutions and universities, but also coalitions towards ensuring that majority of the policymakers and get to know what universities and institutions are doing is critical for the evidence that would like to be projected up there for eventually for action. I will not show a lot of these pictures, but just to, my point was to really make the point that it's very important to get the country into the movement, the decision makers into the movement of what we are doing, so that then eventually that evidence is used, because is taken up because of the fact that it is already known. You will keep updating them, and then eventually, when it comes to flow of parliament and allocations of resources are done. I would like to stop here in the interest, in the interest of time. Yeah, thank you very much. So on this note, I would like to invite my colleague to make the next presentation. Thank you.
Thank you very much,
Yes.
I'll just say a few words to sort of set the scene a bit. I don't have slides, but I'm really pleased to see this session take place. And thanks very much to the Health Effects Institute for the invitation to be involved in this session. I've been involved in capacity building or capacity strengthening for air pollution exposure science and epidemiology for several years now in India, and now more recently in Mozambique. And what I see is really a lot of momentum to increase capacity on air pollution monitoring and air quality control in sub-Saharan Africa, which is really brilliant. But what we need also is the focus on health effects. So I think this session is a really exciting opportunity to bring the health effects dimension into all of the exciting work that's going on. We're obviously still improving the methods for estimating the health burden attributable to air pollution globally. In the past decade, we've really increased the number of studies and the geographic coverage and studies that provide the evidence that we need to do a better job at that health burden estimation. But when we look at what is available in terms of that evidence, it's very clear that sub-Saharan Africa is still very much underrepresented in terms of epidemiological evidence. So I think everyone who's here knows that there's really a major data and evidence gap that remains for I would say sub-Saharan Africa in general, but I know this is focused on East Africa, and that it's essential to strengthen the research capacity to address that gap at multiple levels, at the individual level, institutional level, and also sort of how they interact with the governments as well. So it's very exciting because this is what we'll hear about more today. And I think we'll hear some really excellent examples of approaches that work. This capacity, everyone who's been involved in capacity strengthening knows it's very challenging and requires a lot of persistence and determination. But I think we're going to hear some really nice examples of things that have worked very well. Obviously, the GeoHealth hubs are a very nice example of that. And just on a more personal note, I'm very pleased that we're going to hear more from the PATS MECOR program. A few years ago, I had the pleasure of being an external examiner at a university in Belgium for a PhD candidate from the Democratic Republic of Congo. So he passed his exam, and it was really a clear success story of the PATS MECOR program and what can really be quite transformative for someone to participate in one of these cohorts that goes on for several years. And so on that note, I will invite our first speaker, which is James Matwari, who is currently based at the KEMRI Clean Air Africa Global Health Research Unit, where he is a senior research fellow, principal investigator, and co-director of the unit. He was formerly the dean of the School of Public Health and a senior lecturer in the Department of Health Systems at Amref International University. And James has worked in various departments within the Kenyan Ministry of Health, as well as the Ministry of Planning and National Development. So I think has a very interesting perspective there from both the research side, but also working within ministries. And he's now very active, leading several international research projects on air pollution, energy, and global public health, including the UK NIHR research on technical solutions to clean energy access in Kenya. So James, over to you.
Thank you very much, Catherine, and thank you very much, everyone. And I'm sure you can see my screen. May I check whether you can see my screen? Yeah, I will be discussing with you this afternoon in the next few minutes some of the exciting initiatives and, of course, also innovations that Clean Air Africa is supporting in strengthening air pollution and research in East Africa. I will omit, because we're also in Cameroon where Professor Mbachu is, but I will not be talking about Cameroon here. I'll just restrict myself to East Africa. Now, first and foremost, what made us to think of supporting activities pertaining air pollution and health in East Africa? We looked at that time actually was around 2017, and we looked at the data that was available at that moment. And globally, we found that 3.8 million people were dying, not dying, but were using polluting fuel. In sub-Saharan Africa, about 80% of the households. And in Uganda, Tanzania, and Rwanda, and Kenya, where we are working or supporting, the situation is as worse as you can see there. But now this leads actually to premature deaths, of course, that are attributable mainly because as we concentrate on household air pollution, to about 2.3 million globally annually. These are very premature deaths. But in sub-Saharan Africa, it's close to almost 700,000 deaths. But Kenya, of course, is not also is also not spared because we are losing 23,000 deaths per year. And this is purely household air pollution. And it is underestimated because if we use a different data, you will find that we are losing close to around 29,000, it's actually not 23,000. But now, Clean Air Africa, usually what it is doing to alleviate this problem It's of course trying to strengthen the national health system for community health prevention of also the operation-related diseases, and also provide evidence-based recommendations for the population now then to transition to clean cooking in the households, and also clean energy in the institutions and institutions. Here I'm talking about hospitals and the schools, of course prisons, and the very many colleges we have in the country here and East Africa in general. Now, the sustainable development goal 7, of course, is about more than reliable energy for all, and it has set a target of achieving clean cooking by around, the target is 72% for the entire population of the world in 2030. However, we have looked at the existing trends, how the implementation of adoption of clean cooking is taking place, and what we are saying is that if nothing is done, absolutely, or things remain the way they are at the moment, then Kenya, the world would be short of about 30% to meet the target of the 72. But more worse is Sub-Saharan Africa, where the miss will be very high at 60%. Now, then, how are we working as Cleaner Africa? We are working as Cleaner Africa through the funding from National Institute for Health in the UK, with the University of Liverpool and the Kenya Medical Research Institute being the coordinator of providing the directorship to the countries where we are. That is, I will leave Duare because it's in Cameroon. That is Makerere Lung Institute in Uganda, Moi University in Kenya, Rwanda Biomedical Center in Rwanda, and the University of Dar es Salaam in Tanzania. We collaborate also within this project with the World Health Organization in Geneva, and in the countries where we are. Then World Food Program, UK Aid Modern Energy Cooking Services, the Global LPG Partnership, the Bakari Campus, Bakari Monitoring Group, which is the US, then Sakongas, and also the 625 Teachbox Limited from the UK. Partnership, we keep on also having other partnership through MOUs. Like here in the country, we have an MOU for of course, scaling up adoption with the Office of the First Lady for the Republic of Kenya. Now, in regard to the to our aims that we have we implement in this project, our aims are normally aligned within the Sustainable Development Goals, which you can see over there. And we have aim number 1, which is to facilitate the transition for the vulnerable communities and the public institutions to clean cooking for positive health, climate, and gender. And then second one is to evaluate and quantify chronic and health burdens, and particularly here we're talking about the bans and scans that occur in the communities. And then aim number 3 is to advocate for disease prevention from reductions in air pollution through health system strengthening. And number 4 is to develop a Sub-Saharan Africa a pollution center of excellence for, of course, carrying out training and air quality monitoring across the East African, but we are supporting other Sub-Saharan countries, like you have mentioned already, Cameroon. Then aim number 5 is maximizing impact through community and stakeholder engagement. So I want to go now one by one, and under aim number 1, what we are doing in Kenya, we are trying to evaluate the LPG adoption through smart meters, which you buy LPG based on the amount of money you have. You can buy even as small amount of 200 to 5 shillings in Kenya. It's just like the way you also pay the tokens for electricity. So this is one of the models we are trying to evaluate at the community level. And then we are also in Kenya and Tanzania trying to evaluate LPG exclusive use, particularly in respect to the behavior change And here we are trying to evaluate the impact of text messaging to see whether they have an impact for people to shift into using clean fuel. This kind of health messaging through text messages has been very successful in some countries, particularly in adoption of other health interventions like immunizations, like also antiretroviral drugs, and reminding also patients on the time to take or the need to take anti-tuberculosis drugs. Then in Rwanda, we are evaluating the LPG exclusive use through pressure cookers, and here in Kenya, way back, we and of course evaluated two efficient pots, which gave us very useful findings, in particular in respect to saving time and also cost saving, and of course reducing the respiratory diseases among the populations within the urban setup. Now, the other activity is where in Kenya we are trying to evaluate adoption. This is the strand where I was before. Now, away now from the communities, we move to the schools, and in the schools we are using, we are trying to evaluate, of course, adoption of LPG, but this one actually we are using already an existing financial model for Equity Bank, where we have recruited about 2,000 schools to carry out the evaluation to see how they shift, and we are also looking at the health and cost impacts upon, of course, the shift done in the schools. But again, we also adding another component in the schools where we are trying to look at the effect or the impact of also the pollution and the cognitive performance of the children in the schools. In the health facilities, we are doing some work in Uganda and Kenya, and here we are trying to evaluate the bans. And in the hospitals or health facilities, what we are doing, we are trying to look at the existing records, and then we of course now relate it with the activities that took place, and then again in the communities. We are looking at the bans prospectively, and then of course these bans we also relate them with the activities that take place on cooking. We want really to see whether technologies and the fuel that is being used, what kind of that kind of technology and the fuel can be blamed for the bans that exist within the communities and also the hospitals in Uganda and Kenya. Of course, even in Cameroon, they are doing it, but I don't want to include that one because that one is outside East Africa. And in regard to capacity strengthening, respect to, of course, training, and here we have quite extensive activity that we are doing. And they date back from 2018 when we realized that there are quite a big burden exerted by also the air pollution. Yet out of the 13 community health modules which were developed to train the communities and pass messages to the households through a battery of over 100,000 community health volunteers who have now been baptized as community health promoters, and now the government has even put them in the payroll so that they can be passing messages to the households on various preventive aspects of health, and particularly now that we have this Clean Air Africa supporting Minister of Health to develop this module 14. it's one of the initiatives that we are finding it can be very impactful, and we have piloted it during the development of the module, and found it is very, very, very impactful in terms of reducing, in terms of shifting from polluting fuels and also reducing the associated diseases. So the training manuals that already developed with support Clean Air Africa, and the accompanying job aids that are used by the community health promoters to pass the messages into those households. And we work through a technical working group, which is called Climate Change and Environment and Health, where we normally meet after every three months. A Minister of Health provides leadership in terms of chairing, and then Kemuri being the host and also being the secretariat. This manual, because it has been very, very useful, it's now being adopted through the support of Clean Air Africa in Uganda and Rwanda, and to some extent, let me mention also outside East Africa, the Cameroon. Then now, because these countries we are talking about a large population who should be reaching these health messages for them to shift to clean fuel. Some areas are very difficult to reach. And if we continue face-to-face trainings, it may take a long time. So Clean Air Africa is piloting a digital platform we normally call Teachbox. This Teachbox is able actually to train without even without any internet and without a facilitator, of course, being on site to the participants, and also collect data from the households using the data tools that are developed in Kenya, which we hope they will be also adopted in other countries, on also the air pollution and other preventive aspects. In Kenya now, what has even happened in respect to when we talk about this data collection at the community level for household air pollution, I think we are now leading in Africa, because what's happening is that now we have developed a sort of indicators on household air pollution based on the indicators that are reported under MDG 7. And we have worked out with the Ministry of Health, we are supporting the Ministry of Health. They have now included those indicators into what you normally call electronic community health information system. And this system was launched by the president on the 20th of this month. So we are now expected to be seeing real data streaming from the households up to the national level, and it's accessible to other people to see what changes are there in the households in Kenya. Further to that, and this is extremely very exciting, is we have supported, Clean Africa supported with the establishment of the first Sub-Saharan Africa Center of Excellence for Air Pollution. And this center is the only one in Africa. We have checked around and we haven't seen it, where we have state-of-art gravimetric filter weighing and analysis lab. It's actually a robot. There is very little human interaction when it is doing the pre and post weighing and its own analysis. Then, of course, we have air quality monitors, the gravimetric one being the UPAS, the rate scattering. We have the purple air, and the center is able now to measure PM 2.5, carbon monoxide and dioxide, nitrogen dioxide and sulfur dioxide, and we have now very highly trained technicians working in that laboratory at the moment. It hasn't been launched, but it is still operating, but it will be launched, and the first lady of this Republic of Kenya has already accepted to launch when she will be invited by the Minister of Health to do so. Now, this Center of Excellence, of course, through the partnership with the Bakery Air Monitoring from the UK, has now trained trained staff, and it have been trained on class and also field-based trainings. And this activity was done just a few weeks back, so to make sure the center runs very well with the quality analysis taking place. Then of course, the center is supporting research standards and monitoring components of public and private institutions, which are seeking to seeking to be analyzed. And then again, the center is going to support also the air pollution monitoring for the 7 counties using, and the other sub-Saharan African countries, using, of course, the trained community health assistants who are out there and public health or environmental health specialists. The other very exciting thing about this Center of Excellence is this other software where the center now is launching. It has already, the center, we have already developed three short courses for 6 months each to of course, support or promote scale up of reduction of household air pollution in the sub-Saharan Africa. And one of the courses is health practitioner training in air pollution, energy and health. Then we have another one for health journalism and public health communication. And the final one is health impact assessment. All these courses are being offered but at our cost. The center is offering mentorship, support for academic trainees, particularly the 9 PhD students that the program has supported, and about 3 postdoctoral research associate fellowship who have been recruited for a period of for 5 years, 5 years from now. And we are offering all these courses with accreditation from the Kemri Graduate School, which is affiliated to the Jomo Kenyatta University before we become a university of our own. And then in respect to impact and management, we recognize that any research we do in the community, any trainings we carry out in the communities, our planning begins with, of course, engaging the communities. And we have what we normally call a community engagement and issue steering committee, which is chaired by a very renowned expert in community-based empowerment and public health with Professor Wele. Professor Wele is actually one of the recipients of the Noguchi Prize, which is the biggest award for people who are working on health matters in the community in Japan. And she was in 2022 actually the nominee for the Nobel Prize, but she lost it to Ukraine. You know, Ukraine, maybe the person from Ukraine became very competitive because at the time they were at war. Then community representatives from each focus country is within this committee, and of course their input into all aspects of the unit's activities through the governance structure. Documenting success stories is one of the activities that this component normally does through those countries. I don't want to finish here without saying I'm making this presentation on behalf of Green Air Africa, ran through the directorship of Professor Dan Pope and Dr. Risa from University of Rubaku, and myself from Kemri. And with that, I want to say thank you very much for listening.
Well, thank you very, very much. We appreciate your presentation, Professor James, for this interesting presentation that had different perspective, the community perspective. You moved into the schools, and you're also networking not only in East Africa and the 7 countries, but also beyond, even though you really focused on East Africa. Thank you. And the questions, I think, have been noted, and the comments, they will come in at their time after we have listened to this coming presentation by the next presenter, who will present ably on promoting education, training, and research on lung health across Africa. So Professor Bachu Hugo is currently a professor of pulmonary medicine and at the Faculty of Medicine and Pharmaceutical Sciences at the University of Douala, and also he is a consultant in respiratory and occupational medicine at the General Hospital in Cameroon. So Professor is also not only professing, but also he's president of the nation, is president of Cameroonian Chest Society and vice president of the Pan African Thoracic Society. He definitely, given his exposure, has done a lot. He's participating in several international scientific committees and different organizations. And Professor Bachu is also a fellow at the American Thoracic Society since 2019, just before COVID. So Professor is extremely passionate with research on air pollution, and as such, he has led several studies in East Africa and South and beyond, and he collaborates a lot with the United Kingdom institutions. So happy to listen to your exciting presentation, Professor, and over to you for the next 15 minutes. Thank you.
Thank you very much, dear Chair and all. Before I start, I would like to thank Health Effect Institute for inviting Pan African Thoracic Society to this webinar. So following my colleague James Mutuari from Cambridge, I would like to present to you Pan African Thoracic Society course called MECOR. And I will proceed by presenting first the Pan African Thoracic Society, which is a major professional organization representing lung health in Africa. And it is a respiratory society made of healthcare professionals who are interested in respiratory medicine. It was created in 2003. And we currently have more than 1,000 members from 65 countries and guests in Africa and beyond. So the aim of our society is to promote lung health in Africa. And as you know, the continent is the most affected by morbidity and death due to respiratory diseases. And specifically, we are promoting education, research, advocacy, and optimal care, and the development of African capacity to address respiratory challenges in the continent. Our society, our organization is also the member of another international society, which is the Forum of International Respiratory Societies, which include other chest society like American Thoracic Society, European Respiratory Society, and International Union Against Tuberculosis and Lung Diseases. Our activities are made of training, as I've said. We also have scientific sessions like webinars, and we meet every 2 years. Our first Congress was in 2016 in Nairobi, Kenya, and the second one in South Africa, Durban, that was in 2018. And because of the COVID crisis, we couldn't hold a Congress physically. And lastly, in June, we met in Mombasa, Kenya, for the third Congress of our organization. The training is one of the main objectives of Pan African Thoracic Society. And about 16 years ago, Stephen Gordon from Liverpool School of Tropical Medicine was the one who initiated the program called PAST MECOR, Method in Epidemiology, Clinical and Operation Research course. And this was based on the American program called ATS, American Thoracic Society MECOR program. And when initiating this course in the continent, it was supported by Sonia Bust, who is a past president of American Thoracic Society. And this program in Africa is coming after the American program, which is the Latin America MECOR program. And today we also have this program in China, India, Southeast Asia, and Turkey. As objective or need when creating this program, the different needs were the insufficiency of capacity in our continent to collect and interpret our local data. There was also the insufficient understanding of research, appraisal of literature, and most critically, the insufficient numbers of healthcare professionals, notably public health academics and clinician leaders who could support and facilitate research and its application to public health and healthcare related to respiratory diseases and critical care medicine. And you can see on the right that with our population, which is about now 20% of the world population, we have only 2.5 of clinical trial research being conducted in Africa. And at the same time, we have about 1/4 of world diseases burden in our continent. So it was so important to build capacity of Africans. This course is designed mostly for pulmonary clinicians or any other physicians interested with respiratory medicines. We also include academicians, public health professionals. And we have 3 levels each year. And the duration of course is 1 week. In level 1, the main objective is the measurement of the burden of diseases. So they receive lectures focused on developing study plans, selecting study subjects, prepare and estimate sample size. And they should also develop a protocol by the end of the week. So, and this level has the larger number of students, usually about 20 to 25 students each year. In level 2, which is after level 1, we have the advanced clinical research method. And the lectures are on study designs, data collection method, research data analysis. And usually to attend level 2, you must have attended level 1 years prior to the level 2 year. And we have usually about 10 or 12 students in level 2. And the third level is level 3, where we have research skills to be more developed. And by the end of the week, learners should come up with the draft of a manuscript, and they should also draft grant writing. And to be accepted at the level 3, the student must be able to demonstrate how level 1 and level 2 courses have advanced their research career. And we usually have 4 to 6 students in level 3. As you can see in the pictures, it's a face-to-face week training with the faculty. You can see what we did this year in Mombasa. In last June, we had students coming from 15 countries. And you can see on the table that we have quite a lot of applications. And finally, we had about 46 of them who attended the different levels with many faculty. You see 8 faculty in level 1, 6 in level 2, and 5 faculty in level 3. And during the course, a part of this intensive training on research methodology, we also have other training like spirometry training. We have air quality monitoring training. And during the training, we also have a statistician and some of the mentors who can receive students for different advices on their career. So concerning the outcome of the program, This publication last year was looking at the effect of pacemaker training on the publications of students. And you can see in the graph that within the year, after the 1 year of training, we have the number of publications which has doubled in comparison of the number of publications 1 year prior the training. This is for the student attended the lecture. And if it is 4 years back, we had about 32 publications from the student, and 4 years later, more than 150 publications. This shows really the impact of the training on the research skills of learners. And the papers are published in the journals of good impact. You can see here 80 papers since we start the program published in the Lancet. So I was talking about the different trainings during the workshop or the 1 day prior to the workshop. We have usually have a workshop on spirometry training and a workshop on air quality monitoring. And this year in Mombasa, the faculty in charge of the AQM, air quality monitoring, they were Sin Simple from the University of Stirling, who has a huge background on the research on air pollution. We also had Benoit Nemery from Belgium, who is also a reference in terms of occupational medicine and environmental health. And the third faculty was Babatunde Awokola from Liverpool School of Tropical Medicine, who has also a lot of publications on air pollution. We had 42 participants from different countries, from West South Africa and central part of Africa, as well as East Africa. And the content of the training was focused on showing the burden of air pollution. And in terms of practice, learners could come out with skills in measuring PM particles using low-cost monitors like Purple Air that was shown by James a while ago, and also using another monitor, which is LASCA, showing how to measure carbon monoxide. It was a 1 day workshop. You can see the two monitors here, the Purple Air, which use laser to measure PM 2.5, PM 10, and PM 1 particle, and LASCA, which is very practical for the measurement of carbon monoxide. And this picture is not from this year, it was from 2019. And at the end of the workshop, the different participants could receive a Purple Air to conduct different studies in their setting. And before I continue, I will also say that at the end of the 1 week course of the pacemaker course, usually participants or learners present a topic, and when back in their country, they should work to collect data. And quite many of these topics developed are on air pollution. As papers published on air pollution coming from what Pan African Thoracic Society has done as work on air pollution, we support this study, developing the questionnaire for lung health in Africa course, the LIFE course. This was a program called Impala, and several questionnaires on the assessment of air pollution could be developed. As you can see here, we developed a questionnaire to assess the energy used in different households, to assess the air pollution, indoor and outdoor air pollution. So this study is available and the different questionnaires are also available on internet. Following the distribution of purple earth, as I said, a study was conducted in different countries of the continent, and each participant had to monitor air pollution in his country. We had, I think it was 8 countries with 15 sites of air pollution monitoring. And we come out with this result of the 1-year air pollution monitoring, and we could see the different level of air pollution in our different countries, with a higher level of exposure to PM 2.5, more than the 5 micrograms per meter cube recommended by WHO. We could have, as here in Douala, values of more than 100 microgram per meter cube. So this study is not perfect, but it's a showed us, it gives us an idea on the level of air pollution in our different cities. And because of the training of different participants at PassMaker, we could see, like in this map of air pollution for those using purple air, we now have different sensors in some parts of our continent. We could see in East Africa, in southern part of Africa, and in central and western part of Africa. And most of these monitors comes from students who attended the PassMaker program. So, Mr. Chair, this is my last slide, and I would like to invite those who wanting to participate to the next PassMaker. It will take place in October 2024 in Lagos, Nigeria, and the application will be open in April 2024 on the website of Pan African Thoracic Society. We are targeting, as I said, about 45 students. Thank you very much.
All right. Thank you so much for this presentation. We appreciate it. And since you have put a small commercial, I also say that in East Africa now we have a direct flight from Entebbe to Nigeria. So who knows, we might come. So thank you very much. And your presentation was interesting. We were able to see the different training programs. Captivating was the training research methodology all the way to the publications, which were extremely impressive. We need stock, I think, privately. 80 publications, Lancet. That's a really rich, very rich harvest. Thank you for being very, very successful. So now I open this to the community, to the participants, to ask questions or comments to both presenters. I know that my colleagues have been tracking the online questions that were coming in. However, I will give opportunity to also to those who may have direct questions to ask, so that then we can have, we can have an interactive possibility. So I would like to invite questions and comments. Questions and comments should come in.
As we're waiting for questions to come in from the audience. I'd just like to ask, what, in your opinion, do you think is the most important factor behind the success of the PassMaker program? It's obviously very successful and it's really a nice model. So what do you think is really the most important thing? The sort of bringing people together in person, having the opportunity for people to come back year after year, the high faculty to student ratio, or all of the above.
Yeah.
Thank you very much, Catherine. The week, of course, is really a great occasion for participants who are mostly healthcare workers, most of them can be at the bachelor level in the university or master level in the different universities. Some of them as candidate, are PhD candidate, and we also have clinicians and public health participants. So a part of learning research methodology, learning how to draft different papers, we also meet we also have participants from different countries. They share different experiences, and we have a lot of mentors. We have many faculties coming from different settings, Europe, US, and Africa, and it's also an occasion to discuss with them and have maybe some opportunities concerning the careers of participants. And during this program, usually we have, these big mentors who give presentations, special presentations, showing maybe their career, how they grow in their career. They have sort of, inspiring talk that really can boost youngs to really engage in research career and have hopefully a bright future. And something which is also good is the follow-up, because when you have attended level 1, we are expecting you in level 2, in level 3 with the results of what you have developed as protocol in prior level. Thank you.
Do we have any questions? I don't see any questions so far in the Q&A box.
I think just sorry, I can see Jacqueline Kajima also in the panel. She is the Secretary General of the Pan African Thoracic Society. She may have some comments to my presentation.
There's also a question from for both of you presenters. How can international organizations, funders, and scientists be most helpful, strengthen regional capacity? Maybe it's a question that you could do. Either of you could attempt.
Can you repeat the question, please? Because I can't see it on the screen.
How can international organizations, funders, and scientists be most helpful in strengthening regional capacity? Who wants to?
Maybe I can start, and then James will follow. I think it is doable, and it is what is being done for us in Pan African Thoracic Society. Our program is supported by American Thoracic Society, by European Respiratory Society, and we usually include all this program within a grant. So when members of PATS, with the support of some of our members in UK or US, we could apply for a grant like like we applied for the 5 past year. The program was supported by NHA grant from UK, and before that we were also supported by another grant. I think it was from Wellcome Trust, and I think this is something which is doable. We just need to develop a project and then see how an organization can fund it. And I also think that some other organization like Health Effect Institute, WHO, and some others, they organize capacity building training sessions regularly.
Yeah, yes, I will not say anything very different from what Professor Mbacho has said, But ideally, for international organization, honestly, to fund, of course, applications must be done, especially when there are antibiotics out or the beans are out. Like ourselves, we work and we are funded by the National Institute for Health Research in the UK, and it's a bid which was just advertised. But one thing I know is that it is always important for the middle income countries to identify and work with a country that is from that country where the advertisement is made for the support or the funding. And then of course there should be a very clear gap, maybe even some work was already done, some work were done, but gaps were identified. And of course, it's again in an area that is, of course, to me, exerting a very high disease burden. And again, it's an area that the country also has put as a priority, because if it's not a priority for the country, and particularly when it is research, some countries need to come up with what we normally call research priorities for the country, so that any funder who is funding through research priorities. And these priorities, they are just not written down, they are arrived at scientifically to prove that that is where the gap is, and is going to address a certain, particularly when it is addressing a disease burden. The funder, the probability of funding increases. And then remember somebody said from the beginning, and I think it is you, Lane, who said in the beginning, that proposals that touch many countries, they attract also higher funding. So those international organizations are looking at, are we looking for evidence for only one country? Is one country going to tell us the position for other countries? So the more countries you pick, but with its own complications of coordination, again, if there is the strength of the team to coordinate, that kind of partnership also gives a very strong sense. So that is my take. It's not very different from what my colleague from Professor Mpachu has just said.
So I will continue with a question for Bertrand. So what do you consider as the greatest challenges or opportunities for sustaining educational programs on air pollution and health across Africa?
Thank you very much, Catherine. I think what we are expecting with this training program is to have evidences on the reality of air pollution in our different countries. So if you could have some of trainees who can go back and then collect some data on air pollution is something which is a positive, it's a start. And secondarily, we should also gather off this data and start advocating toward the policy makers, so that they could do something to reduce the burden of air pollution in our different areas. And James was saying, was presenting the burden of air pollution, and we are concerned in Africa with household air pollution, mostly in rural area where we use wood, where we use charcoal for lighting or for cooking. So I think with all these evidences, we could convince our governments to do some actions to reduce the level of air pollution in our households. And in Cleaner Africa, we had a program to promote the use of cleaner fuel like LPG, and these are some products which can be subsidized by our government, and by using LPG we can reduce the level of household air pollution. So these are different output we could be expecting from the training that we are giving in our program.
Thank you very much. Are there some questions online? Please, you could ask interactively. You could also send a question in the chat box that you are responded to before we come close at the wrap up. I have a question for James. Maybe James, Professor James, you could answer a question regarding your experience working with government at policy and research. You've been in universities and now Cambridge Research Institution. How do successful capacity strengthening programs respond to local and international needs? Because sometimes we have read and understood that sometimes the agendas of the international community may not necessarily be at tandem or in rhyme with those at local level. How do you harmonize the two? Recently, I was in Nairobi, and I think Dr. Hugo wanted to take me to eat nyama choma somewhere, and I don't know what happened, but the taste of the meat is quite different. How do we ensure that we harmonize those local cultural needs with those of the global community?
Now, local versus now global. One, of course, it is important for us to note, and I want to go back to say that without data, you may not actually, from the local, expect much support from the international community. But again, I also want to say that one of the things, particularly in this area of air pollution, which is likely to be a big catch, which can be a very big catch, is first and foremost, we need to look at where are the funds coming from that can support this area, strengthen this area of air pollution and research. Is of course trying to also not just link air pollution to only health. There are those ones who are more interested, as an example, in terms of how does it translate in climate change. And when we talk about maybe we are destroying the environment, probably cutting down the forest even to half, it translates into several metric tons, and these metric tons translates to quite a huge volume of carbon dioxide emitted, and of course, in the atmosphere, they of course now causing global warming. That one actually can attract the international community. The other thing which I wanted to guarantee you is that the international community at the moment is very much interested with how the grants are normally managed. So if you have a good financial grant management, certified, like the way Professor Bachu Duar Hospital, I think you already certified, the international community actually feels their funds are very safe, they are not at risk, But again, I also want to tell you that if I take you back once during the primary health care days, remember before 1978, when before the declaration of Ramata, health for all in the world, many people in the world were conscious about how health is. They thought health was almost the same globally, but that kind of interaction made them to be aware, and that's why they picked it very well. So what I'm trying to say is that it's important the international community, when they are doing particularly the scoping mission, they get as much information as possible, provide also come up with the gaps, and once the gaps have, of course, been identified, then that one makes it supportable. Otherwise, the international community and the local community, if they are not talking, and particularly this talk can be encouraged particularly for this area, can be encouraged during the COP, either 28, 29, whatever it is, or the various climate summits that you interact with the local community. But again, when you look at the Ministry of Health, like the Ministry of Health Kenya took a lot of time to even recognize that air pollution is causing many premature deaths. It is purely because we do not have actually adequate evidence. Adequate evidence that would say we can use it for Treasury to allocate those funds. And without allocating those funds again, the international community sees that there is no commitment, and when there is lack of commitment, it becomes a big problem. And remember, the international communities out there, they are coming up with the various declarations. How countries are trying to domesticate those declarations is what will attract now the international community, certainly, to support these gaps, in particular strengthening the area of air pollution and health.
Okay. Thank you very much. Let me see the time. It's now getting to 10 minutes to the end of our presentation. I'll just, if there are there any other comments or questions before I can give my closing remarks and pass it on to my colleague?
Yes, Lee?
Yes.
Yes,
any additional?
Also,
yes, go ahead.
Yes, I would also like to emphasize a point concerning the training of healthcare providers on air pollution. If I look at what is happening in my country, you know, air pollution and health is a chapter which is not really very important in the different programs in different schools. Even in medical schools, you may see medical doctors who have graduated, and they cannot tell you what is the really effect of air pollution on health. And if you go back at the level of college, university, you have the same thing. So that's why in Cleaner Africa, one of the objectives is to, for my country and for some other country, is to advocate at the level of the different Ministry of Education, how they could insert a module on air pollution and health in the program, in the training program of nurses, of community health workers, and even of medical doctors, for them to use this knowledge and know how to assess the air pollution when they see patients in their different clinics, and they could also give some advices to patients that they receive in their clinics. So because we receive many patients in hospital, and sometimes we see that their conditions is related to the level of house or air pollution in their different homes. So that's the point that I wanted to add.
I would also like to add something else, and particularly my experience at the university and also at the Ministry of Health. And of course, even the minister I was working also, because I worked also with the Ministry of Planning. And of course, I also worked with, anyway, Office of the President, is that I have noticed actually at times it's very difficult to find the researchers who are scientists talking to the policymakers, and even bringing to now when you come up when a country comes up with a policy, I mean, not a policy, but a policy for implementation, it has already avoided using the evidence that is already generated, because the researcher did not talk to the policy maker that we are doing this research, or we have developed a policy brief, or we have or you have carried out a science cafe to make to bring these people together, the policymaker, the researcher, the implementers, and also even the beneficiaries together, so that they see this is a problem and they talk one language, and that language can actually attract the international communities and also even the funding agency in the country. So this has been a very, very big gap, and this is what actually our project is tending actually to improve on. So we intend actually to bring these people together, and we want to bring them together, of course, through a science cafe, through science cafes, or just half a day, not like a conference, and then now all of them now table the evidence they have. This one's table what they have in their policy they have developed. Then the implementers also table what guidelines are they using to implement, and is it what? And then the beneficiary, of course, now comes up with the problems that they're having, and from there, of course, now they can marshal a very strong a proposal, and they can be listened actually by the international community.
Thank you very much. You actually summarized what I wanted to say, that dialogue meetings, a dialogue between community, policymakers, and technocrats is extremely very important for policy for uptake of results eventually that get implemented. In Uganda, we have experience with the breakfast meetings seem to be very attractive, because then they end by 9:30 and people get on, these very busy people get on to their other work. Breakfast meetings, policy briefs, because these parliamentarians they want to read very easy things. I mean, things that they can understand quickly and advocate. We have examples with the Center for Tobacco in Africa here in Makerere, where uptake of the recommendation and legislation was quite fast, because we were able to convince policymakers of the cost of taking care of cancer patients vis-a-vis the income that was being brought in by British tobacco BAT companies, and so we need to move into that direction. Then I think research, that multi-country, multi-center research, as you said, is very important, because then you have evidence from different sources and you pull the data analysis together and you have a bigger picture and stronger results, which is a good thing. And we are trying to do that under the GeoHealth Hub. Then maybe I can just, as I conclude, say that communication, having communication officers on our projects is important, because then they keep actively communicating ad hoc results or even updates to the world, to newspapers, to the other platforms is a good thing. And also they can be able to put the results in perspective, so that then one sees how, for example, a fifth of the population death can be attributed to air pollution in cities. Such results easily can make people move faster in making decisions about investments into air pollution. So lastly, I want to really say that infrastructure for air pollution is very expensive, especially in low-income countries, including East Africa. I'm happy that KEMRI is launching a program, but in our experience, getting our filters weighed and post-weighed, the equipment, when it breaks down, you spend many months without assessing. Monitoring is important. And then lastly, from me, the integrating training institutions was important. Like it has been said by Dr. James, medical students and public health specialists should be exposed to the monitoring equipment, so they are familiar with them. So that if they see patients, then they can quickly click to part of their investigations, think about air pollution. I turn it over to my colleague to make her closing remarks. Thank you so much, and I appreciate all of you for attending. Over to you.
So thank you. It's been a really interesting discussion, and I think what I've really appreciated was that we started very much with the question around data and research gaps and building capacity more on the research context, and are finishing really focusing on the knowledge translation side, which I think is a really important part of this story, which is not only do we want to be strengthening individual researchers and institutions, but it's what I think I just heard in the last few minutes was really the need to basically translate what we do know already, and really the importance of effective communication to specific audiences. So communities, which we heard about, healthcare professionals, and policymakers, and how important that work is. And I think we're just out of time here, so I will leave it there. And I believe, I don't know, Victor or Pallavi, if you have some final remarks.
Thank you, Catherine. Let me just share my screen here. So on behalf of HCI, I would like to thank our co-chairs and panelists for finding time to share your experiences, and really applaud you for the very critical work that you're doing in terms of the programs that you're leading by example, and hopefully we can find some more time to discuss some of these issues. So in Kenya, we say asanteni sana, merci beaucoup, thank you very much. I would also like to say that this second webinar was brought to you in partnership with the Pan African Thoracic Society and the Respiratory Society of Kenya. A special thank you to Dr. Jacqueline Kagima, who is with us today, was part of the panel, for really working hard to help us to put together the agenda and the speakers, and working with us to sort of bring you this second part of the webinar series. So as you will see on your screen there, we've been building this conversation from a data conversation to a capacity conversation. And I'm happy that Lind mentioned aspects of communication, which we will go into at our next webinar on November 29th. This is just a day before COP28 begins. So we hope you can join us for that conversation. And lastly, just to thank my fellow HCI colleagues and staff who have worked in the background to set up this webinar for you. So thank you very much. And we hope to see you in the next one on communication, which will be the last one for this year. And asanteni sana. Thank you.